The subject now is the echocardiographic evaluation of myocardial viability. In other words, if we have a left ventricular wall with no contractility, how to know if there is viable myocardium or not? How echocardiography can help? Let's see some initial concepts. What is a viable myocardium? Viable myocardium is that one which does not have contraction before being revascularized, and after revascularization and restoration of perfusion, the contraction returns. This is the final certainty there was viable myocardium in the revascularized wall. The return of the contractile function may happen quickly, within days, or may take close to 6 months or so. What is non-viable myocardium? Is when that wall which was not contracting remains with no improvement after restoration of perfusion, even as late as 6 months after revascularization. That indicates that the myocardium was already dead in that wall, and the revascularization could not make the wall contract again. The restoration of perfusion was obviously not necessary if we could know beforehand that the myocardium was not viable. Echocardiography can recognize easily the myocardium that is certainly non-viable. The wall will be thin, will show no contraction, or may be dyskinetic. The left ventricle cavity may be locally dilated, and there we will have more echogenicity, meaning it will be brighter than the other walls. We have no doubts it's non-viable. There will be no need for other tests. No need for Dobutamine stress echo, nuclear studies, or whatever have you. There is no possibility of viability in this situation. Here, an example. In a situation like this, where there is no contraction in the posterior wall of the left ventricle, the wall is thin and brighter than the other walls. This is non-viable myocardium. The difficulty with the diagnosis of myocardium viability is when there is no direct evidence of non-viability, as shown so far. The LV wall may be akinetic or dyskinetic, may have normal thickness and echo brightness, similar to the normal contracting walls, and nonetheless, the myocardium may be non-viable. Then, a single echocardiogram does not define if it is viable or not. So, in the clinical scenario, we have to identify what is happening with an akinetic or dyskinetic wall that has no direct signs of being non-viable, and hence it could have both possibilities. It is just a wall with no contraction, and we have to decide the reason for this lack of contraction. We cannot just revascularize the wall and wait for the results. Many unnecessary revascularizations would be performed. We have to know what is causing this wall to stop contracting. Is it necrotic? Is it stunned? Is it hibernating? Is there any possibility to recover wall motion by revascularization? If the myocardium is not viable, there is no need for revascularization of that particular wall. But if there is viable myocardium, then yes, it should be revascularized, not only to restore the wall contraction for a better ventricular systolic function, but also because it has been proved that the survival of these patients are better than those not revascularized. It may be viable and should be perfused, or may be non-viable and there is no need to revascularize. We have to recognize these possibilities. The myocardium may be hibernating, it may be stunned, or maybe necrotic. Let's continue discussing some concepts. What is hibernation? For example, let's say that this wall is not contracting, and after reperfusion, the contraction returns. It might be hibernating initially. The wall had a perfusion problem that brought a contraction problem. For the time remaining the perfusion defect, there will be a contraction defect. Since the perfusion is below the necessary to the myocardium contract and remains alive, it ceases contraction in order to remain alive. When perfusion is restored, the myocardium restarts immediately its contraction. This was then a hibernating viable myocardium. What is stunning? There is a non-contraction wall and no immediate improvement of contraction right after reperfusion. It takes a variable time, weeks or months, for the contraction to return. So there was viable myocardium, but different from the hibernation, the improvement was not immediate. In this case, there is a perfusion defect. While the perfusion was decreased, so was the contraction. Then there was revascularization, but instead of an immediate function restoration, it improves gradually and may take several months to return. This complete return, although late, shows that there was viable myocardium. If the wall is not fibrotic, basically, then those two conditions that we will find in a wall without contractions are they may be hibernating or stunned. Both situations, the wall will return to normal contraction after revascularization, immediately if hibernating and later if stunned. But we may have some variation within stunning and hibernation. He may have a brief period of ischemia with a gradual return of the perfusion. In this situation, the function will follow the perfusion and will return gradually too. Or he may have periods of silent ischemia and with it small periods of wall dysfunction that are present at the moment of the echocardiogram. One more situation that we have to be aware of is the so-called no-reflow phenomenon or reperfusion lesion. In this case, there is a wall that we had studied before and it was viable. Then it is revascularized and contraction does not return. Apparently, there are many factors involving the microcirculation in this case, including endothelial damage and myocyte edema existing before the revascularization. With the revascularization, there are furthermore fibrin, platelets, and leukocytes plugging of the microcirculation that increase and expands the area with no reflow after the revascularization. What happens after revascularization? Let's say that there was a wall without contraction, but there was no fibrosis, and we thought it had viable myocardium. But after revascularization, it persisted without contraction. What may be happening? Well, maybe this region was already necrotic, and we erred to diagnose it as viable. Another possibility is that the ischemia is persistent. The myocardium was hibernating before and after the procedure to revascularize it was not successful. Or it may be stunned now. Revascularization was successful, but the myocardium now is stunned and will remain so for a long period before returning to contract. Another possibility is that now we have a reperfusion lesion, or the no reflow phenomenon. The wall was viable before, but now is non-viable. Let's see it in another way. To begin with, what we ought to know is if this non-contracting wall is necrotic, fibrotic, or hibernating. Is it viable or non-viable myocardium? Once decided that this is a viable myocardium, we're going to revascularize it. If after revascularization the contraction returns, right away we know that the myocardium was hibernating. And if the contraction does not return, then we may mistake the initial diagnosis of a viable myocardium and there was necrosis that we did not diagnose. The other possibilities are that the myocardium is now stunned, or might happen a no reflow phenomenon. What time may show us? Well, if contraction returns lately, this myocardium was stunned. If it doesn't return, then the myocardium was necrotic or fibrotic or had now a non-reflow phenomenon. We can detect myocardium viability using stress echo, for instance. If there is a wall with no contractility and with the stress does not contract, while the other wall increases their contractility, there is a good chance that the myocardium in that wall is not viable. But if that non-contractile wall now starts to contract, probably it's viable. If the wall had no contraction and after stress became dyskinetic, then it's possible to be viable too. Usually, this stress is performed with Dobutamine, and a better sign for viability is when, with a small dose, the non-contractile wall starts to contract, and later on, with increasing dosage, it stops contracting again. This kind of response demonstrates that there was a viable wall that became more ischemic with further stress. This so-called double response to the Dobutamine test is the more accurate sign of viability. If there is no change with Dobutamine and the wall remains akinetic in spite of larger dosage, then the myocardium is non-viable.